Hello.
Good morning.
Good morning.
Can you hear me, Suzanne?
I
Good
can.
morning.
Okay, better go that way. Hi there.
Good morning.
Good morning.
How is everybody today? Good?
Hey, how
hear
are
me?
you?
Good.
Can.
I'm happy
Doing
it's Thursday. Yeah, Thursday.
It
Happy
is.
it's Thursday. Absolutely. I think we'll wait for a few more people to pop on here.
Sure.
It's tax day, by the way. Just in case you're wondering.
Yeah.
Such great news, Allison. Thank you for sharing.
Yeah.
Right?
Well, I was just like,
Yeah.
I just got a notice from my accountant. That was what I was like, oh, yikes. So,
But it's extended until,
Right.
the deadline's extended until
Isn't
like
it May
July
7th?
or something,
May
right?
17 or something, maybe?
Or is it just
Yeah.
May?
yeah,
I think it's a month, yeah.
extended unless you have to make payments or something. So
Can you hear me?
you have to do them today. Yeah, we can hear you, Joe.
Hi, Una. How are you? Oh, good.
Hi, Debbie. Welcome. One of our new members. Nice to see you here.
Hi, Debbie.
And Jen, hi Jen, welcome.
Hi.
Hi. Yeah, welcome. Welcome to all the new ones. Jennifer, welcome.
Hey Dylan, nice to see you.
I can't wait till we can do this in person. I am
I
so
know.
excited to meet everybody in person, right?
When do you think that might be?
Maybe fall, maybe November is what I'm thinking, maybe.
I'm
hoping.
with you. Yeah, I
Don't you
agree.
think?
Yeah.
You're the
We should-
expert.
We should
Dr.
ask the expert on that for sure.
Yeah.
It's a guess. You know, it all depends on how well we behave.
Yeah, that's true.
You know, the
Well, there's
virus
no hope then.
doesn't care. It's
Yeah,
it's
virus
us.
doesn't care. You're right. Hi, Artie.
Oh, there she is, Alyssa.
Hi, Artie.
Hi, Audie.
Alyssa.
Okay.
Hey,
So,
Lisa, how are you?
Christine, you
Good,
tell me
thank
when you
you.
want me to start.
I think we could probably go ahead and get started now.
Want me to get started?
Yeah.
All right. Well, welcome everyone and happy Thursday. I can't believe the week's almost gone. One more day left, right? Happy Thursday.
Crazy.
Goodness
Period.
sakes. I can't believe it. Anyway, I think I know everybody on the call, but I'm Suzanne Hensing, the chair for WISH. Happy to be here. Happy to have you here. This is going to be a phenomenal presentation today. It's a unique presentation today, and we'll talk about it in a minute in more detail, but today is very casual. We're going to ask questions directly to the presenter. We're not going to worry about the chat session, but again, I'll talk to you about that just in a few minutes here. We have quite a few members, quite a few new members, and welcome to everybody. And we have some folks that are not members, and we hope that you become members and join us because we are a great group of women. So we'd love to have you. Few housekeeping issues, just 3 short little housekeeping issues. Number 1, we do have our next session, which is scheduled for May 6th. And that session will be on activating music memories. It's more about Alzheimer's and memory loss and dementia. And so we're really looking forward to that presentation. That will be on May 6th. On September 23rd, you remember we kind of take a break over the summer, if you will. On the 23rd of September, we have integrative medicine in cancer. Couple presenters going to be really phenomenally exciting. They're from MD Anderson Cancer Center and Banner Cancer Center. And it's an interactive presentation on helping people through chemo and radiation and the process of cancer. In November, we're going to have a fundraiser. We don't have a date yet, but it will be one you don't want to miss. It will be absolutely fantastic, probably breaking us up in smaller groups and visiting people's homes. We'll have a dinner and we'll have about 10 people. That's why I'm thinking we can do it in person. We'll have a dinner scheduled for about 10 people at individual homes with the same chef, and we're going to have a great program. So I'll get a date for you, but I don't have that solid yet, but that will be in November. The second thing I wanted to mention is you got a flyer, and if you got a lunch, not everybody wanted lunches today, but if you have a lunch, in that packet is a flyer. And one of our new membership benefits is you can get a 50% discount on membership at the Arizona Science Center, which is quite a deal. You become a President's Club member. It includes all the benefits of complimentary general admission, special events, private tours. They do some phenomenal things, some very interesting things, and it's worth every penny. So you get a 50% discount. So keep that in mind. The third thing is today's session is recorded. If there's a ton of material today, you may want to review it again so you can ask Christine for a copy of the presentation. Perhaps one of our membership was not able to listen today. They certainly can get a copy of the presentation as well. So again, it's recorded, so your questions will be recorded. So the very last thing, getting into the presentation, is it's unique, as I mentioned earlier. It's a unique presentation because we're all going to participate. Dr. McKellar is going to present different sections regarding COVID. I've had the honor of reviewing his slides, and he has such interesting material, information that probably you really wouldn't be familiar with. But after each section, and it'll be pretty clear when he's done with a section, why don't you raise your hand and just say, I've got a question, or just spout out your question. We may have a couple people, talking at the same time, but we'll work through that. We felt since it's a smaller group of about 32 today, it would be easier. Plus he likes that format and he's very good at that format. So he works a lot with students. So I feel like we're all his students today. So feel free to ask questions. You don't have to put them in the chat. If you do put them in the chat, I'll try to catch that and then ask those questions later. So with that, I would like to introduce you to a phenomenal physician and a very good friend of mine who I've known for probably 35 years. Dr. Peter McKellar is who I'd like to introduce you to. He is an infectious disease physician. And some people don't know what an infectious disease physician is. He says it's like an internal medicine physician, but we take better history. What he does is he diagnoses patients who have obscure infections, bacterial, viral, whatever. He takes care of patients. He teaches residents and has taught residents for years. He's great, fantastic with students, actually. And he's been investigating and researching new antibiotics since about 1976. So he's very involved in patient care, teaching, and research. I want to mention to you way back in the old days, I'm pretty old, so way back in the old days, in the 1980s, in the neuro ICU, we would have a patient come in and they had some kind of virus or bacterial. We couldn't figure it out. Antibiotics weren't working. Antivirals weren't working. And we would call Dr. McKellar. So Dr. McKellar would come up with his white coat and his name, right here, his big name right here in his jacket. And he would be there, and within usually a few hours, we'd have some kind of diagnosis back. So he was like the magic guide. When you call him, you knew you're in trouble, and he would always bail you out. So I have to say that about him. He's super smart and just took care of patients in the most wonderful, wonderful way. He's been in the Valley since 1976. He was a graduate of New York Medical College and did his residency in internal medicine, and then went on to do a fellowship in infectious disease at Rush in Chicago, Rush Presbyterian St. Luke's Medical Center in Chicago. So he was a Midwesterner. He was the director of the Division of Infectious Disease from 1981 to 2017 at Banner University Medical Center. He still teaches. He doesn't see patients today, but he still teaches and he does research. We're very fortunate to have him. He has written numerous publications, numerous abstracts, numerous clinical investigations. I couldn't even begin to share them. His resume and bio is about this thick. I wanted to share a little something about him. On his mother's side, I don't think he's going to appreciate me saying this, but on his mother's side, he is a direct ascendant of Aaron Burr. A direct descendant of Aaron Burr, and really he has no similar traits as Aaron Burr, but because he is an absolutely wonderful physician, a caring person, a lovely guy. And I want to introduce you to Dr. Peter McKellar. Take it away, Dr. McKellar.
Thank you, Suzanne, for those kind words. I've got to tell the audience that Suzanne, as a nurse, and all the nurses that I worked with are the ones that kept me straight and honest, and kept me working, and kept me able to help patients. So it really isn't just one person. It's a real team effort, and without good nursing, you're in real trouble. I found it always helpful to ask nursing beforehand, and then after I'd finished seeing the patient, what do they think is going on, and what are we missing? Because sometimes they were spot on. Anyway, let me start us off by pointing out that I don't have a specific agenda here. I'm going to go through coronavirus and give you some ideas about how it presents, how we diagnose it.
Going with computer. I did that. Continue.
And is everybody hearing me? Am I
Yeah.
still?
Yes.
Okay, good. And I'm going to start off with maybe 4 slides at the most, and then at any time as we're going
Nothing
along,
happened.
if questions pop up, I want you to feel free to ask, because that's what I want to entertain. But I want to try and keep it in a format where we start with talking about the virus, then talking about the clinical syndrome and the diagnosis, and then the prevention or vaccines, and then some problems. And in short order, we'd be finished, I suspect. I wanted to first point out that with this slide, the difference between fungus, bacteria, and virus, because it gets my gall periodically when the newspapers say that we have a flesh-eating virus causing problems. It's usually not a virus at all. It's usually a bacterium, and it's usually Streptococcus pyogenes or group A strep that's causing that flesh-eating problem. But fungi, and out here in Arizona, cocci or valley fever is the big fungus that you have to be aware of, are much larger than bacteria, and bacteria are much, much larger than virus. This picture here is of a blood smear under a regular microscope under high power, and you see red blood cells in the picture. And I don't know whether I can point them out. These things are red cells. These are white cells, and they're all inflamed because there are bacteria in here. And this is a sepsis picture. And where that arrow is up top is a bacterium that turns out to be Streptococcus pneumoniae, or the common cause of pneumonia. And this bacterium is probably 500 times larger than any virus. So we wouldn't see virus under a regular microscope. We'd need electron microscope. That's just to point out the difference between fungus, bacteria, and virus. And I ought to also mention that all the fungus and the bacteria can be grown separately without other cells. Viruses cannot exist without some cell that they can then invade or be grown in and take over the cell mechanics and reproduce themselves. Let me have the next slide, please, Lauren. Let's go into what this process is all about: severe acute respiratory syndrome, coronavirus, and give you some historical background too. But we're talking about SARS-CoV-2, which is the infecting virus today. That's the one we're concerned about. It causes the disease process COVID-19, which stands for Coronavirus Infectious Disease 2019. You can have the virus in you and not have the disease. And let me say that again, you can have the virus in you and not have the disease. Those are asymptomatic people. And that's part of the problem with COVID-19. There are too many folks out there who are asymptomatic, have zero symptoms, or are pre-symptomatic. In the first 5 days, for instance, they may have no cough, no fever, no chest pain, no symptoms of a viral syndrome coming on, and they're passing on this virus. So they become super spreaders. But COVID-19 is the disease process. I'll probably stay with the word COVID-19 because it's easy. But remember, it's due to this SARS coronavirus number 2. With that, I ought to point out that there've been, this is the third pandemic of coronavirus. Actually, it's not really a pandemic of the others, but it's the third major coronavirus just in the last a little less than 20 years. The first one was in 2003, and that was the severe acute respiratory syndrome coronavirus 1. That had a 10% mortality. There were less than 9,000 cases in the world at the time, and it started in China. We didn't see it in the United States with very little exception. It got to Canada, but really didn't get into the United States, and then it stopped because of very careful quarantining and hygiene, and it was probably a little less respiratory spread than is the coronavirus or COVID-19 coronavirus 2 that we're going to be really honing in on. The second one you should be aware of is that in 2012, there was this MERS-CoV, which is Middle East respiratory coronavirus, that had a huge mortality. Fortunately, not too many people got infected because it's not human to human contagious as contagious as is the SARS or COVID-19 is. And probably SARS-CoV-1 wasn't quite as contagious person to person as is COVID-19. So this MERS came from the Arabian Peninsula, high mortality. It's from camels, and you really don't have to worry about it unless you're in, let's say you're in somewhere in the Middle East in a camel market. Don't kiss any camels. Big deal here. The big important point for all of you to remember is there's a spectrum of disease here, and it's from asymptomatic to pre-symptomatic to really sick. And it just has a huge spectrum. You can't really predict it. Let me have the next slide here, please, Lauren. This is a schematic of the virus, and you can see that, I don't know whether my pointer works, but is that working as a pointer?
No, but that's
No.
okay.
Okay, I won't use it then. This is the virus cut in two, and it's the coronavirus, obviously blowing up because it's only at most 100 nanometers in size. And a nanometer, just for your reference, is 1/1000th. That's a B with a billion, or a billion with a B of a meter. So it's really small, but this is cut in half, and inside you can see the ribonucleic acid or RNA. And on the outside, very important, are these S proteins, which are spike proteins. These spike proteins are crucial for attachment to different tissues in the body, but in this case, it's in the lung. This is lung tissue, and they attach to what's called an ACE2 receptor. These proteins are very important because that's what, through genetic sequencing, we've been able to figure out is what we should make an antibody to. And that's exactly what the Moderna and Pfizer vaccines have done. They've taken and made an antibody to this S protein, and so has Johnson & Johnson, but they use a different vehicle to make that vaccine. And we'll get into the vaccines in a minute. But the key here is the virus has to attach by those spikes. It gets in then into the cell, takes over the machinery of the cell on the right side there, reproduces dramatically. And in the process of reproducing, these RNA viruses make a lot of mistakes. They have errors in their reading of their code and what they're supposed to make. And that becomes sometimes a problem because they produce variants that way. So that gets to the question of how can we stop that? And one is to shut down the number of people who have COVID-19 so that they're not spreading this and producing more variants. That in a nutshell is how this works. Next slide here, Lauren, please. I told you it's from asymptomatic to pre-symptomatic to really sick. And I've got 3 slides here, kind of out of order, but the first one is a normal chest X-ray in a patient who actually had a positive PCR test in a nasal swab for coronavirus 2. So he doesn't have COVID yet, but he has the virus. And it's a normal chest X-ray, no symptoms. Very important to remember, this patient could easily be contagious. The far right slide is Chris Como of MSNBC, I think. I got that off the internet, and he got coronavirus, got sick enough to probably need oxygen at night, but did need hospitalization, and he has a mild viral pneumonia on this chest X-ray. I won't go into the particulars of it. The lady in the middle is a disaster that happened in Chicago, and a 22-year-old lady, I think in April or May last year. She was a marathon runner, and she ended up getting coronavirus. And this is her lung just before she ended up getting a double lung bypass. The lung is just wiped out. You don't need to be a radiologist to know that it doesn't look good. Next slide, please. So that's the spectrum, everything from asymptomatic to really sick and needing significant help. And of course, as you all are aware, we now have in the United States over 560,000 people dead of coronavirus. This is not new. These pandemics have happened. And start with the bottom one on this slide. This table kind of shows you very nicely what's happened over the last little over 100 years. In 1918, just as the World War I was ending, we had a pandemic of influenza. We didn't know it was influenza. We didn't know what it was. We just know it was killing people. And look at the number in the US that died in 1918, 1919 during the pandemic, 675,000 people. That's more than have died so far in the United States today. But keep in mind that in 1918, in the United States, the number of people living here was like 75 million. We now have over 4 times that number of people. So this was a huge deal in 1918, and it decimated the world. You see 50 million people died, and we didn't have therapy for it. We didn't have therapy for the bacterial super infections that occurred on top of the influenza. Some of this, though, was primary influenza pneumonia in young people. We were worried this was going to come back. If you go up to, I think it's in 2009, just the second line from the top, 2009 H1N1, that's the name of the virus, the influenza virus. It looked like it was coming back in 2009, and that was kind of scary. In the United States, we had over 12,000 people die. Fortunately, that virus did not continue to be a problem, but it could be down the road, it could be a problem. We've had other pandemics. Back in 1957, we had a pandemic that killed 60,000 of influenza. In 68, we had another pandemic. And just as an aside, influenza usually kills around 40,000 people in the United States every year. That's a rough guesstimate, but many of them have underlying illnesses that make them more prone to getting serious illness or dying with the influenza. We're not over the COVID pandemic. The COVID-19 pandemic is still with us. It is not even close to being over. I'd love to tell you it was, but I don't see it being over until we all get together and say, hey, we're going to do the right thing and make sure that we don't continue to spread this. That's a tough lift in a country that's very heterogeneous and not homogeneous. And in a country that's not autocratic. You can find countries, though, in the world who have done a marvelous job with COVID-19. For instance, Taiwan, country of 25 million people, they've had 10 deaths from COVID-19 since this started. 10, maybe 1,500 or 2,000 cases, but at most 10 people have died in a country of 25 million. Now we're over 10 times that number, but we're not even close. I think we represent 4% of the world population, and we've got close to almost 25% of the COVID in the world. So we got a lot of work to do. Other countries, particularly in Asia, have done a marvelous job. You don't have to pick on autocratic ones. You can go to New Zealand and see that they've done a marvelous job too. They're a country, though, of many fewer, 2 million, 2.5 million. And their numbers of deaths are dramatically lower than others. I think that's the last slide, I believe. So let me open it up here and go into a couple other things that I wanted to touch on.
Peter, before you do that, I'm just
Sure.
going to ask, does anybody have any questions so far of Dr. McKellar? Any questions? If you do, just speak up. All right.
So that was as clear as can be, huh?
Yeah.
There'll be a quiz at the end of this. And before I go on, let me quiz you just real quickly, because this is something that's is great at a cocktail party, which will have to be on Zoom for a while. And that is, what virus can you think of where we have a vaccine that has totally eradicated that virus, basically from a clinical problem since 1980?
Oh, maybe.
I can give you some thinking music in the meantime.
Dylan, did you have it? She's one of the people.
Well, I was gonna guess polio.
Nope, wrong. And in fact, let me add that polio still exists. There are 3 countries that have it, Afghanistan, Nigeria, and Pakistan still have it. Not huge, but they still have it brewing. And the other problem is the oral vaccine, the Sabin vaccine, which we no longer use in the United States, is a live vaccine. And sometimes the live vaccine actually causes the polio virus to cause a problem. Not common, really uncommon, but that's a problem. Nice guess, wrong. I'll give you a clue. 1792, Edward Jenner noticed that these milk maidens who milk cows all the time never got this disease. They did get a cowpox, but they never got smallpox. Exactly. And so he realized that maybe if I gave people cowpox, I could vaccinate them. He didn't call it a vaccine at the time, but he did that, and lo and behold, it turned out to work. Now we've cleaned up smallpox vaccine dramatically since then. It was no longer cowpox that we were giving, but we don't need it anymore since I think 1977 they stopped using it in the United States. That's just a pearl. Smallpox is eradicated, except for it's unfortunately in some laboratories in the world, but not a problem clinically. Moving on. Incubation period for corona or COVID-19 is 1 to 5 days roughly. And that means you got the virus, you're going to get sick. How long does it take? Some people get sick real quickly. Some people take considerably longer, but 5 days is usually the limit. Can go 14 days before you're really sick, but by and large, if you're not sick by 14 days, you're not going to have the illness, but you may have the virus. Remember, you can be asymptomatic and have that virus, so you can spread it. That means even if you've been vaccinated and everybody else has been vaccinated, best wear a mask, particularly around people you're not sure of. So the incubation period is up to 5 days, significant pre-symptomatic transmission of this virus, and maybe as many as 20–25% of people are so asymptomatic or mildly symptomatic that they have the virus, but they don't really have what we would call COVID-19. And those are the people who turn out to be the super spreaders of this disease process. It comes kind of as in clumps or clusters. It's not like flu where you're really not contagious until you get sick, meaning you got the illness. Flu doesn't really have a pre-symptomatic stage usually, but coronavirus definitely does. So I would guess that probably up to 20% of patients or people with coronavirus or COVID-19 are the ones who transmit about 80% of the virus. And it differs in that way from flu. There aren't the super spreaders that you have with flu. Questions about that? Anything pop up?
I do. I have a question.
Sure.
So if the incubation period is like 1 to 5 days, if someone is asymptomatic, what's that time period when they're no longer able to spread the virus? I mean, because if they
Probably
don't,
good question. Probably 14 days. It depends on the host meaning the patient. A healthy host, by 14 days, if they haven't spread it and they haven't had the disease process, they're probably not contagious. Because what happens is they get a viral titer. They get the amount of virus in them starts to diminish after the first 5 days. But if you're not a healthy host, say you've got some bad underlying disease process and you name it, you figure those out, then it can be a lot longer. There are some patients who have, say, underlying cancer who have actually been shown to be contagious for 3 weeks or so with COVID-19. So I'd be cautious there, depending on the host. Any other questions there? I should point out that I don't know the case fatality rate for COVID-19 because we don't really know how many people have actually had it because so many are asymptomatic. The guess is somewhere between 50 million and 100 million people in the United States have had COVID-19. How many have died? Well, you know that figure. That's about 560. So it turns out to be under 1%, but flu is probably closer to 0.1%. So COVID-19 is a lot more deadly, particularly in bad hosts, than is influenza. How do we diagnose it? I'm going to move on quickly to diagnosis. Clinical picture helps, but the COVID-19, like other coronaviruses and other viruses in the respiratory tree, look very similar to all of it. Looks like flu even. I forgot to mention that there are actually 7 coronaviruses out there. 4 of them just cause colds, just normal colds, and they're relatively harmless. 3 of them I've just mentioned, SARS-1, SARS-2, and MERS, Middle Eastern Respiratory Syndrome, are the other 3 coronaviruses. How do we diagnose it then? If it's by clinical, you don't. You just know that if they're at high risk and we're in the middle of a pandemic and they get a viral syndrome presenting as fever, chills, myalgias, or muscle aches, weakness, a cough, chest pain, you name it. Any organ system can be involved, by the way. You can have a skin rash with it. You can have a headache with it. You can have kidney problems with it. It's any organ system can be involved. Heart problems, particularly in certain patients, are a problem. But by and large, it's a typical viral syndrome, but that you ache and you have fever and you feel miserable, really miserable. I remember watching Chris Como once in a while on his TV show because it was interesting to see somebody who actually had it talking to you. And he was describing how he felt, and it didn't sound pleasant. As you might well expect. We use the molecular tests, which are called PCR or polymerase chain reaction tests. It's a nasal swab that looks like they're putting it in your brain, but they're not. They're putting it in the back of your nose, and they're leaving it there for 10, 15 seconds and rolling it around to try and get material. And then they can do a PCR on that. It's not a culture. And in fact, if you have a positive PCR test, it doesn't mean that you have live virus there. There are some people who, after they've had COVID, can still have a positive PCR 2, 3, 4, maybe even 6 weeks later. but they're not that, we can't grow that virus out usually. In a bad host and an abnormal host, sometimes we can grow that virus out. We have some rapid tests that are used, but they're not as accurate as the PCR test. The PCR test just takes a little longer. It takes 6 hours or so, and sometimes you have to bunch them and do them, and you don't get the results back for a day or so. The rapid tests are useful if they're positive, because then you do a PCR and make sure they're real positive, really positive. We don't do viral cultures because of the risk of spreading the virus, except in research settings. And that's basically how we diagnose this. It's not difficult to diagnose. It's usually fairly straightforward. Questions about that before I move on to maybe touch on origins of this virus?
I have a quick question on the testing. Why are the rapid tests not as accurate as the PCR tests?
Yeah, they're not looking at the nuclear material, the RNA. They're looking at an antigen, usually an antigen that is a byproduct of that RNA. And they're real quick to do, but their accuracy, depending on who makes the test, can be anywhere from 40% up to maybe 80% or so, and maybe higher. I had heard that in Europe they have better rapid tests than we do in this country. We've had problems with their testing. I can't tell you any more than that. It would be neat. They're working on rapid tests that you can do at home so you can quickly diagnose yourself. Those will eventually come to market, but right now they ain't there. Other questions about it?
Yes, Dr. McKellar, we have another question for you from Elisa. There are stories of spouses/partners where one gets it and the other doesn't. Who is doing research to figure out why?
Yeah, it's interesting because they've been looking at that in that setting. They've given the remdesivir monoclonal antibody cocktail subcutaneously to exactly those people. And they've shown that it really works to protect the person who hasn't gotten the disease. The answer is one is multifocal or pronged here. One is that it's they just got lucky, and they were very careful, and they used masks and hand hygiene, and they stayed quite a distance from the person who had it, and the ventilation in the place they were living was excellent. And the person who had the active disease didn't perhaps have a high viral load. All of those are possible. Second one is, and don't forget this, a fair number of people, up to 25%, are asymptomatic or totally without symptoms the whole time. So maybe that partner had it, didn't know it, okay? And that's the dilemma with coronavirus here. COVID-19 isn't like flu. When you got flu, you know it and you can spread it when you got it. With COVID, you can spread it when you don't know you got it. And that can be a real problem down the road. There are probably other reasons for why what you asked occurs, why one partner doesn't get it, the other does. And I can't think of them at the moment. Other questions before I go on to the origins here real quickly?
There was another question in the chat that might relate to that, and it's just, how many people do you think are immune? In the 1918 pandemic, I believe there was something like 60% of the population was immune. Do you have any insight into that?
I don't know how we'd know the 1918 immune status, but we do know that we can check for people who are still alive from then. And there are very few, obviously, but they do have antibody, or they do have evidence that they had been, if they ever got infected, that they still have immune protection. I think in the United States right now, if we look at say 50 million people got it, and some people say it's 100 million people who have gotten COVID so far, those people are immune. How long is not clear. It is clear that the vaccine gives you more immunity than the real disease. That's important. The vaccines that we're using for COVID-19 have better immune protection than does the primary virus. There are a few cases, not a lot, of people getting COVID-19 and then getting it again. That happens. And it's hard to prove because you have to obviously isolate the virus. You can't just do another PCR. That PCR may have been positive all along. So you have to isolate the virus. But by and large, I think that there's a fair number of us who are immune. That's why we're looking to get population immunity or herd immunity, what's called herd immunity. You reach a certain number and then there'll be fewer people getting COVID-19. Unfortunately, that's not a switch that clicks on and off. It's not like everybody got vaccinated, so we're not going to see any more of this, because not everybody gets vaccinated. Look what happens to measles. Measles was no big deal for a long time, since roughly 1980s when the vaccine came out. Then we started screwing around with not getting vaccine in some people, and we had outbreaks in clusters around the country of measles last year. Had a huge outbreak.
Mhm.
And measles is a virus that can kill you. I've seen measles as encephalitis, and it's not pleasant. So I think the immunity from the virus is probably there. They suggest now that if you got the virus, you definitely had it documented, wait about 3 months before you get the vaccine, but do get the vaccine. That's the recommendation. If I had if I got COVID-19 last month, I'd get the vaccine today, quite frankly. I've already had the vaccine, but I'd be in a hurry to get what really definitely works and has, now we know, at least 6 months of protection. Other questions before we go into origins? Where did this come from? Coronavirus. We've seen that. I told you there's 7 coronavirus out there. 4 of them caused colds. 3 of them caused real bad disease. Lots of bad viruses we tend to blame on bats. Bats are wonderful mammals that if we didn't have them, we'd be infested with so many insects, we'd be in real trouble. On the other hand, bats also tend to be harbor a lot of viruses. And we tend to do things with bats that we shouldn't do. And some of that is obviously stupid, and some of it is just by going into a cave and the bats were there. So you can get lots of things from bats. Bats probably transferred this virus to other animals. Civets are one of the animals. It looks like a cat to me. I don't know what it really is. A bunch of other animals are suggested. And then it crossed a species barrier. That's a big deal, a species barrier. A lot of these viruses in animals just stay in animals. I mean, a lot of dogs get different viruses that we never get. And they don't get measles. They get Rinderpest, and that's why they get vaccinated for it. And that's kind of like measles. So there's a species barrier. Humans tend to stay with their own species, but that sometimes fails. It failed with HIV. It clearly failed with HIV. And sometime back in the early 20th century, the virus of HIV went from a chimpanzee into a human, probably due to bushmeat. Bushmeat being, if you've ever been in third world countries where you go into their markets and you'll see all sorts of animals you can't recognize that are being sold for slaughter and for eating purposes. And that meat gets, in chopping it up, you cut yourself and the blood from the meat gets to your body. And that's probably how HIV jumped to species. Same thing happens with coronavirus. I don't know whether it was a lab accident or animals. That doesn't matter to me at the moment. I first knew about this on January 1st. And that's because I monitor a online journal called ProMed that tells you what's going on in the world with infectious diseases. And I thought it was interesting. And then on the 11th, the Chinese researchers published the genetic sequence of this virus. That's 11 days after it was first talked about on ProMed. And I thought, gee, that's strange. And they're either really good or they were ahead of the game. And as it turns out, the Chinese had been working on coronaviruses, just like we work on coronaviruses for years, especially after SARS-1 and MERS, which we've already talked about. And then on the 20th of January, China shut down Wuhan City, a city that's kind of like Chicago, but considerably larger. It's 10 million people. They just totally shut it down because of the outbreak. And they also censored some Chinese doctors. That's because they're autocratic, but it also suggests, are they hiding something? It bothered me a little bit by then. And then by the end of March, we knew there was a super spreader problem, and the rest is history. It just took off. And that's the origins in a nutshell. Any thoughts on that? Any questions? I'll go into treatment real quickly, and then we'll get into vaccines. None. Okay, treatment. Most are mild and they can do well at home. I would suggest if you had COVID-19 at home that you invest $40 and get a pulse oximeter from Walgreens and put it on your finger just to make sure that your oxygen saturation in your blood doesn't drop, say, below 90. Because if it did, that might be a suggestion that maybe you should seek some care in the healthcare system. But mostly it's supportive at home, deep breaths, different positionings, and it goes away in a couple of weeks. Although it doesn't stay away necessarily. You may get better for 5-6 days, and then suddenly you start getting short of breath and get severe pneumonia. So you're not out of the woods until at least 14 days into the disease process. There are no easy to give treatments early on. They're either intravenous or intramuscular or subcutaneous. Remdesivir, which is the intravenous therapy, doesn't keep you from dying, but it does it gets you out of the hospital 4 days sooner than if you didn't take it. So it does have some benefit. The antibody therapies that are given intravenously do help, particularly this monoclonal cocktail that a friend who's making it, Regeneron, I think, makes it. You give it subcutaneously, and that looks, in somebody who's not really sick yet, it looks like it's very helpful. When you're really sick, then what happens is your body starts to get inflamed, and you get what's called a cytokine storm. Lots of things in your body, white cells, all sorts of weird things trying to protect you actually start to kill you. And in that setting, we use high-dose steroids like dexamethasone. More to the point, there are some oral therapies that are coming down the pike that may be really helpful. I won't dwell on them. The one that's not useful is hydroxychloroquine, which looks good in the test tube, but in oral form in humans causes heart problems more than it helps in any other thing. So treatment in a nutshell, there is treatment, but it ain't as good as we'd like it to be. Prevention, very good. Prevention, vaccinations, not vaccines, vaccinations. Vaccines only the first step. You got to get it in an arm. It's no use in a freezer. Masks definitely work. They definitely work. And it looks like the humidity created by a mask may actually help you protect against viruses, not just coronavirus, but influenza as well. Physical distancing definitely helps. Unfortunately, ventilation problems abound, particularly in some restaurants, so that you can be quite a ways away. And if the ventilation is lousy, it could be coming right at you. Turns out that in an airplane, ventilation is superb. They go through HEPA particle screening, and so they're really quite good. Did I see somebody wave their hand, or they got a question, or you just scratching your nose? Dylan, you can talk. Okay.
Well, actually, I am curious on the, you mentioned the airplane is quite, safe with the filters, but what about the airports?
Terrible, terrible. Anytime you're around people, you're in trouble. Okay, especially if they're not wearing masks. Everybody wearing a mask, the risk is a lot less. If you've been vaccinated and you're wearing a mask, the risk is dramatically reduced. It's not zero, but it's dramatically reduced. Remember, these vaccines, even the best at times, they're probably in real life no better than 90% effective. That's damn good. That's really good. There aren't a lot of vaccines. Flu vaccines in a good year is 50% protective. So to have a vaccine that's 90% and low on side effects, that's wonderful. I'll take it any day. Hand hygiene really helps. Let me say a word about taking temperatures. It looks good, but it's nonsense. Only 40% of people with coronavirus will have a fever, and usually they're sick enough so they're not coming into your store or your office. So taking a temperature just looks good. Better to have a bottle, invest in a bottle of Purell and have them wash their hands with it. And that really is not the way coronavirus gets transmitted. This is a respiratory virus predominantly. It's respiratory. You can, with some effort, take it from your hand and put it in your mouth, but it's mostly respiratory. Avoid crowds, avoid poor ventilated settings. Protective equipment was really helpful. And remember, we had a big shortage in the beginning, and I don't have a lot of time to mention it, but I'm going to mention it anyway. Part of that is because in this country, we have gone to a chain of getting equipment that relies on other countries, particularly Asia, and it doesn't work that way. If we need it in a hurry, we got to be able to manufacture it as well. So there are real problems there, real problems. Just as an aside, let me tell you that climate changes things too, and give you a good example of that. Climate caused a hurricane, I think it was Irene, that wiped out a good part of Puerto Rico in 2017. Puerto Rico happens to be where 80% of the intravenous saline bottles come from, or bags, 80%. So I remember in 2018, 2019, we had trouble at Banner getting IV bottles with saline in them. We had to make some of them, or we had to use just glucose or dextrose. And that's a little scary when you run out of stuff. So supply line failure was a big deal. Contact tracing, is that of any help here with coronavirus? Probably not. It's really helpful with sexually transmissible diseases, but it's not helpful in a disease process where it's respiratory and there's a pre-asymptomatic spreading of it. So it's really difficult to do contact tracing. Let's quickly go into to viruses, to the vaccines. I'm running out of time here, Suzanne, I apologize.
Yeah, I do want you to cover vaccines, and in a minute, we've got a question about the J&J vaccine. So go ahead.
Yeah, okay, well, I got all the answers.
All right, good.
And
We are so happy.
You'll buy this bridge that I have behind me here. First off, let me point out that the vaccines, there are 3 out there, 1 on hold, the J&J. The 3 vaccines are all under what's called a emergency use authorization. They're not licensed for sale. That's kind of a big deal because it tells you that they haven't yet been okayed for license to sell. Doesn't mean they're bad. It means we needed them in a hurry. And we've found now with, I don't know how many million have been vaccinated, that the side effects of these vaccines are minimal, really minimal compared to their benefits. This messenger RNA virus vaccine is unbelievable advancement. And it's not new, really. We've been playing with RNA since 1970s, the late 1970s, and the vaccine has actually been used for cancer therapy, or we're trying to get it to be used for cancer therapy. In fact, Moderna and BioNTech, which Pfizer joined with, were doing cancer research with messenger RNA vaccines. And then they suddenly switched a year ago, and here's where we are now. They've done a marvelous job of creating a vaccine where they take RNA, and I showed you the RNA inside that virus schematically earlier. They take that virus, they can actually take that RNA, they can make it in the lab, and they can program that RNA to specifically produce antibodies to what? Remember that S protein, that spike protein on the outside of the coronavirus? They are specifically programmed to make a anti-spike protein. And that's what the RNA virus, the messenger RNA virus is doing. Look at it as following. DNA is kind of like the recipe. It's where all the genes are kept. And RNA, and you're in a kitchen, let's say, and the RNA is the way to get that recipe from the pages into the kitchen. So messenger RNA takes that information from the from the recipe book, the DNA, and takes it to the kitchen where it can then be put into programming proteins. And that's how these vaccines work. Any vaccine, even the one that Ed Jenner made in 1792, what they do is they basically bolster your immune system. They make your system more capable because you've already seen this virus. And so you're ready to take it on. There are antibacterial vaccines as well, but we're talking virus today. So that's how messenger RNA works. The problem with the differences between Moderna and Pfizer are marginal. Pfizer is going to need more work on their messenger RNA to make it so that it doesn't need so much cold storage. That's been one of their problems. When they transport it, they have to keep it at remarkably low temperatures. It looks like Moderna's getting on top of that. The neat thing about these messenger RNA viruses is you can change them fast. We used to have to grow, we still do, influenza vaccine in eggs, and that took 6 months to get a vaccine. With messenger RNA, we can change that vaccine, and in 2 weeks, we can have another vaccine.
Peter, can you talk about the active vaccine versus the non-active and also the lipid transfer?
Sure. With the messenger RNA, by itself, if you injected RNA into the body, it would be rapidly degraded by the enzymes in our body. So what the Moderna and Pfizer have done is they wrapped it in a nanoparticle lipid, a little fat particle. You can't get overweight on this, so don't worry about it. And that lipid particle protects the RNA until it gets inside the cell, and then it dissolves, and the RNA then can take over the machinery of the cell and create antivirus, or antibodies, I should say, to the virus. The other type of virus, the Johnson & Johnson and many of the others, use a different vehicle. They use a virus, an adenovirus in the case of the Johnson & Johnson one, where they have inactivated that virus. They made it so it can't grow, it can't propagate, but they then give it the instructions, the molecular instructions to create a antibody to the S protein on the outside of the coronavirus. And that's how they work. They basically go in and bolster your immune system to produce anti-S protein, spike protein antibodies, so that when the coronavirus comes along, your body's seen it and immediately pops into action. I think the messenger RNA viruses are the way to go, but the Johnson & Johnson one looks just as good long-term. It has run into problems, but if you look at any drug and take 6 million people and give it, I guarantee you'll find a lot of problems. We use heparin to keep people from clotting. We use it all the time in the hospital. And I would say probably 1 in about 1,000 people will get really, really ill. Some die from heparin. They get clotting from the heparin. So any drug can have a problem.
Peter, what do you think? Does that, that seems to, the question here, it seems to validate many fears that the tests weren't ready because now they're pulling back the J&J vaccine. And also the other 2 vaccines are not active virus. I've had so many of my friends ask me that, and it is not active virus. It's not like a flu shot, Moderna and Pfizer. So
that's a good point. The messenger RNA has no virus in it. Whereas the Johnson & Johnson and many others have some sort of viral particle in it, part in it. But so does polio, so does measles, so does rubella, so does mumps. So that's in itself is not a big deal. The bigger point, Suzanne, that's got to be made here is I don't think stopping Johnson & Johnson at this juncture is necessarily bad. I think it tells you that we're doing the right thing. We're looking very carefully, because maybe what we should do now is say, hey, nobody who's female under the age of 50 should get this vaccine, just out of an abundance of precaution. On the other hand, it looks like males have no trouble with it. Older folks have no trouble with it. And it's a one and done kind of vaccine. It's a marvelous vaccine for certain populations in this country that could no way get 2 vaccines 3 to 4 weeks apart. If you go to the homeless population, particularly I go to LA where the homeless in downtown is amazing. You can't vaccinate people down there with and have them come back in 3 weeks or 4 weeks. In 3 or 4 weeks, they're somewhere else. So that doesn't work. So I think Johnson & Johnson did, or the FDA and the CDC have done the right thing. They've stopped. They looked at it. They're going to look very carefully. They're going to compare it to AstraZeneca's problems, and they'll come out with recommendations that will say, don't use it in females who are under the age of 50. I think that's what'll happen.
Peter, we are at 12:32. We've got to wrap it up. How about some closing comments or thoughts?
Long haulers, let me say a couple of things about long haulers. You get coronavirus and it may not be that you're over it. If you read The Atlantic, I think it was in February, there's a marvelous article about long haulers getting coronavirus and staying sick, having chronic fatigue, chronic problems for months thereafter. That's going to be our next hurdle. This is like many things, like Epstein-Barr, mononucleosis, and many other viral problems. It can create problems, and we're just learning how to deal with those. What else could I tell you?
Hey, Dr. McKellar, I think something really important you mentioned when we met earlier this week were the 2 news sources to look for valid information on coronavirus and vaccines. What were those 2 sources that you recommended that people look at for accurate information?
I don't actually recall exactly what I was talking about. I would tell you that one place that you have to be really careful is social media. That'd probably be the last place I'd look for accurate information. I look at Up to Date, which is a journal online. I look at the CDC website, which is very reliable. I look at the National Institutes of Health stuff that comes out. And then if you really want to see what's happening around the country and around the world, you can go to Johns Hopkins website for coronavirus, and it's free, and you can see an unbelievable amount of information. The thing I would caution is watch out for social media. There's a lot of bogus stuff in there. It's so weird, it's scary.
One of the things just that you had mentioned, and if you want to just very briefly comment on it, is what bad shape our public health system is.
Oh yeah, yeah.
Today, it's dreadful. Part of the reason why we're in such bad straits right now. Just in a minute or less.
Less than a minute. We're working on infrastructure, but public health is part of that infrastructure. And you can see this public health infrastructure problem right now in Maricopa County by asking the Maricopa public health people, how much syphilis did we have in newborns? And immediately they'll say it's 3 times what it's been. And that immediately tells you we got a problem. That's sort of a canary in the coal mine. There are lots of other examples of that, but it costs money. It costs money. We have to pay the money if we're going to protect our citizens, and it clearly is worth it.
Very good. And when would you predict our next pandemic will be after this is over?
Well, I'd like to know when this is over, but clearly there are going to be more. I showed you that I gave you that table that has 4 or 5 pandemics. There'll be more. There'll be lots of them because we're living right next to animals that carry this virus sometimes, or carry a virus. We're moving into their territory. The big problem now is a pandemic of drug-resistant bacteria because we use too damn much antibiotic. It's a huge problem. Another one, if you're particularly outside Arizona, is ticks. Ticks are not insects, they're arthropods, and they have spread all over the country, and they carry all sorts of wonderful things. I adore them because they keep me in business. Rocky Mountain spotted fever, which we have here in Arizona on the Navajo reservation due to ticks. So ticks are going to be a big problem. You already saw Zika virus cause problems in pregnancy. Things like that. Dengue is coming at us in a big way. And then if you think yellow fever's gone, think again. It's going to be coming around. And yellow fever is a big deal. It put the United States government out of business in 1790 when in Philadelphia, when it wiped out something like 25% of the population of Philadelphia. And that was the capital of our country in 1790. So there are lots of things coming at us, and we just have to be prepared. I think the infrastructure of public health is really part of it. Just being a knowledgeable person and not relying on social media to give you all that knowledge is really helpful.
Right. All right, with that, we have to stop. I might ask if anybody has any other questions, why don't you send them to Christine? There aren't any more in the chat, but I bet you there's some people ready to burst out there with other questions. And then maybe Dr. McKellar would answer those questions and we can send that out to everybody. So,
I'd be delighted. Yeah.
okay. So you are a superstar. You are my
Oh, dear.
star.
Oh,
And
dear.
I have to thank you so much for today. Isn't he wonderful? I mean, if I had to have an infectious disease physician take care of me, man, he'd be the one to do it, right? He explains things so well. He always did that with the patients and the families. So I think you're wonderful. You've done so much
Thank you
for
so much.
patients and research and the residents. Thank you so much. We so appreciate it.
I've
All
had
right.
a lot of fun, and I'm still having fun.
I know you are.
And
Thank
it
you so
wore,
much.
It wore off on one of my kids. She's an infectious disease doc too.
And where is she practice?
She's at Duke.
Yeah, that's wonderful. That's fantastic. So, all right. All right. You take care. Keep in touch. Okay.
You too. You
All
bet.
right.
Thanks,
Thank you.
Suzanne.
Bye-bye.
Thank you.